vaccine efficacy and safety, and then a little bit also about the UW and Harborview clinical approach to patients with COVID. And we call this post-acute sequelae of COVID. The more general term that's been used is long hauler. So a little bit about myself. You may wonder why I'm giving this talk. I'm a physical medicine doctor, and I'm board certified in brain injury medicine and rehabilitation medicine and electrodiagnostic medicine. And my research and clinical background has been focused on outcomes of patients with critical illness and looking at their functional and cognitive and mental health outcomes after becoming very, very sick and being in our ICUs with sepsis or pneumonia or things like ARDS. I also have a research background looking at neuromuscular outcomes and looking at people's strength and nerve function after severe injuries. So, and I'm also, just full disclosure, I have a couple of consulting roles with private companies like OrthoCare, and I do get some funds from honorarium. So just to give you some disclosures. And then I'm an assistant professor at the University of Washington and teach medicine to residents and medical students. So looking at the pandemic, back in May of last year, we were looking at how sick people were getting from COVID-19. And because of my background in critical illness, we knew that people with these severe infections would have impacts on their physical function, their mental health, and their cognition. So with Jana Friedli and Julie Hodap, we decided to form a telemedicine clinic, which would address some of those concerns for patients who had suffered COVID, but had survived, but may have ongoing issues. So our initial thought was we just have telemedicine, doctor evaluations for patients discharged, and refer them to resources as needed, especially physical therapy for endurance and strengthening, and then other services if needed, like speech therapy or neuropsychiatric testing for cognition. And, as I said, a lot of patients with COVID were really critically ill. And what does that mean? A lot of them have what's called acute respiratory distress syndrome. So essentially their lungs were filling with a lot of water and making it hard for them to get oxygen to their bodies. A lot of these patients were put on ventilators for pretty long times. Some of them needed to be actually have their lungs bypassed and have other ways of oxygenating. So that's called ECMO. And lots of them were on what's called neuromuscular blockade agents, which is a way to paralyze the muscles so you're not using as much energy and oxygen and improve your survival. So those patients, we know if you have ARDS, prolonged mechanical ventilation, and ECMO and neuromuscular blockade, we know you're at risk for a few things. One is ICU-acquired weakness. So that is very common in the ICU. We see patients who are just not able to move as well. Some of them are so weak they can't even lift their arms or legs off the bed. A lot are more mildly weak, where it's hard to walk. It's hard to walk for long distances. They may struggle with challenging tasks like stairs or, putting on clothing. The underlying issue is the nerve and the muscle is often directly affected. So that's called critical illness myopathy, which is injury to the muscle, and critical illness polyneuropathy, which is injury to the nerve. And these can overlap and cause further weakness. There's something called post-intensive care syndrome. So, there's often a narrative when we look at TV and movies, people go in the ICU, they get really sick, but the team saves them and they come out and everything's okay. And everybody high fives. And if it's Hollywood, there's nothing else that needs to be done. But the truth is a lot of patients that come into the ICU, and, if you're a survivor of trauma, you may have experienced this yourself. A lot of those patients will have impairments in their ability to do things that they used to do, like walk, dress themselves, bathe, do physical tasks, go upstairs, changes in their ability to think, and impacts on their mental health, including anxiety, depression, and PTSD, or post-traumatic stress disorder. So really, these patients often benefit from having a multidisciplinary team approach that addresses these complicated and multiple domains, and use rehabilitation strategies and resources to try to effectively rehabilitate them. And at the first stage of the pandemic, we thought, let's use some of those strategies that we had before and try to use them with COVID patients and see if there's a benefit. So, looking at the early stages of the pandemic, it looked like a lot of cases were fairly mild, and there'll be more on that in a little bit, but about 80%. But, somewhere around 19% were severe or critical disease. So pretty severe, either, having trouble getting oxygen or having more than 50% of your lung involved, or, really needing very severe measures where your body's in shock and you're having multiple organ systems injured. And then, of course, we know that a lot of people have died from this as well. And, when we look at these patients, a lot of them require invasive ventilation. So putting on, a tube down your throat and helping you to breathe. Almost a third of the patients in New York needed that. Almost a third needed help with blood pressure support. So, using medications, your blood pressure was so low that you had to have some help maintaining those pressures. And then among those patients that were very ill, ARDS, which I talked about before, acute respiratory distress syndrome, was the dominant finding. So patients, with increased water and fluid in their lungs, and that was somewhere between 40 to 70%, depending on which population and ICU you studied. And many of these patients were intubated for several weeks or even longer, with lots of organ systems affected. So very, very sick patients. And this is from some of the research that I've participated in. And when you look at patients that have been on lengthy mechanical ventilation, about half will have some level of nerve or muscle injury in there if you look at specialized testing. And in patients that have been on the ventilator for 4 to 7 days, about a third, roughly, if you examine them, will have nerve or muscle injury. But if you look with more detailed testing, with something that I do called electrophysiologic testing, almost a third to a half will have findings. So if you look at ARDS, which is the common finding in COVID, anywhere from a third to 2/3 will have weakness. So what that means is just a lot of patients being affected in their ability to move, their ability to have strength, their ability to have endurance in these settings. And we might ask, what does that mean long term? And I think, when we look at patients with ARDS, this is a study that was done kind of in the early 2000s. Many of these patients return to normal lung and spirometry, which is just a measure of lung function, how much you can breathe, how fast you can breathe, how deeply you can breathe, and how much force you can generate with your diaphragm. And these patients pretty much normal by 6 months. That might be a little different in COVID patients, but despite that, 6% continued to have their oxygen go below normal levels when they walked for more than 6 minutes. And muscle weakness and fatigue were the most common reason that people experienced limitations. So that was really the predominant issue for these patients, more than respiratory symptoms, more than other potential causes. So this is very concerning, because so many of our COVID patients are getting this ARDS and having these long stays in the ICU. The other thing was that the endurance was pretty significantly impacted. So, at 12 months, almost a whole year of recovery, people were still only 2/3 of what they should have been at that time. And even more significantly, almost half who were working before were not able to return to work at 5 years. So that's a huge number of people, losing their jobs and not able to return to roles that they were previously, and at a huge cost to their finances, et cetera. So I think the other important thing to note is that critical illness is associated with changes in cognition. So in this study here, they were looking at patients with all comers in the ICU, but about 34% of the patients at 12 months had scores similar to a moderate TBI. And this isn't patients with a TBI, this is patients who are critically ill. So a lot of patients being affected. In another study looking at severe sepsis, about 10% more patients had moderate to severe cognitive impairments after sepsis. So it's a huge number of the survivors of these critical illness stays that are experiencing very significant changes in their cognition. I think the other thing to really think about is, the mental health after stays in the ICU, and it's estimated that anywhere from a third to a half of COVID survivors who were in the ICU will experience depression and anxiety. And I think that probably actually holds true for some of our outpatients and may, in fact, underestimate some of what we're seeing. The other thing important to note is that PTSD is fairly common after ICU stays. So it can be a quite traumatic experience, and patients get significant effects on their well-being following that. Just to dive in a little bit more on what this means to lose strength and lose cognition. So the study looks at patients who were ventilated for more than 7 days and what their function is. And it really sought to stratify them, because there was this question about, well, maybe it's just that old people get sick and old people are at higher risk for disability. So, that's what's happening here. But when you look at this group, so this is a young group, less than 42-year-olds, pretty short ICU stay. So you might expect that those patients would recover unscathed. But if you look at lower body dressing, so the ability to put your pants, your shoes, and your socks on, at 3 months, still almost a fifth of those patients were needing some assistance and not completely independent. But even when you go out to 12 months, somewhere around 10% of those patients were still needing some assistance. And if you're talking about hundreds of thousands of people hospitalized, that's a very significant number. And, obviously, if you're older and at higher risk for disability, those numbers aren't better. And, if you look at this oldest age with long ICU stage, which is the red line, those numbers, somewhere around 40% of those patients are needing some help. Stairs, up to 60% of this older group, still 10% of the younger group. And this one is really fascinating. So that cognitive component, the ability to be independent with your memory, independent with things like finances and remembering tasks like grocery shopping, things like that, is impacted. So our idea, and I just want to be clear that this is all evolving. We're trying to adjust to a rapidly changing field of information and new science and new understanding. So we're having to kind of take our best guess at what we would do and build out from there. And it's also challenging because the numbers are increasing so fast, and there's, we're having to pivot fairly quickly, and that puts a lot of strain on the resources available at the University of Washington and staff. And I think it's a challenging environment for many reasons. But this was our initial thought at building a post-COVID, post-ICU clinic, that we would have telemedicine visits with available therapies as needed, at least until the patient was COVID negative and able to come in. Multidisciplinary team. So I I think the physician has some roles in terms of the medical diagnoses, working up with problems, but it's really the therapists that are able to deliver a lot of the significant care. And I as a physician value their input incredibly. So, physical therapy has probably played the biggest role in terms of getting people back to physical activity, physical function, and exercise. But there's definitely been a role in terms of cognition for speech therapy and neuropsychiatric testing. And the mental health component has also really been significant. So our rehabilitation psychology team has been great, but we need more help, need more people to be able to see these patients. So it's been a very challenging environment just because of the numbers. And this slide is really to show you, what we're seeing. So if you look at patients who have been hospitalized, the kinds of symptoms that patients are complaining of have some pretty specific patterns. One, fatigue has been the number one, and that includes cognitive fatigue. So, there's physical fatigue, like I'm having trouble going grocery shopping, but then there's also, I'm trying to get through my workday and I can only do 2 hours. And, if you've had brain injury before, you're probably very aware of what cognitive fatigue is. Like, you may be able to function pretty well for an hour, but after an hour, you may need a break in order to regroup and rebuild some energy so you can return to those tasks. Lots of other complaints. In this study, they didn't really evaluate cognition, but I'll talk about that in a little bit. Other things that are coming up, dyspnea, especially feeling short of breath with exertion, patients having a lot of pain complaints, joint pain, chest pain, shortness of breath. Some of that chest pain is also associated with very high heart rates. As you probably heard in the media, a decreased sense of smell has also been fairly common. Headache, and this study doesn't assess some of the other things like sleep and post-exertional malaise, but those are things that we're seeing a lot as well. And these symptoms are persisting. This study looked at 60 days post-onset, but we're seeing this even, 6 months to a year out. I think what shifted for us was in the summer, we really were continuing to think of this as a post-ICU, post-acute clinic, but it really became apparent that patients were experiencing a lot of these symptoms, even if they were never hospitalized. So you may have seen stories about long haulers or long-term symptoms, what we're now terming post-acute sequelae. And patients that just really having struggled to return to work after COVID infections, lots of problems with sleep and anxiety and fatigue. So the shift in paradigm really went from, post-critical illness kind of clinic to also direct effects of the virus with, of course, some overlap in those. So in this study, which was predominantly non-hospitalized patients, we look at patients with COVID-19 and, at about 28 days or a month, about 13% had symptoms. And past 8 week, about 4.5, and past 12 week, about 2.3% still had persistent symptoms. And, a lot of times this is not just one symptom, but kind of 7 to 12 symptoms. And 2.3 might not seem like a huge number, but, we're talking about tens of millions of infections, and that number becomes a very significant public health crisis, even though it's small. And this is one of the an international cohort driven by some patient researchers who had background in research and then happened to get COVID and really spearheaded some efforts to characterize what's happening. So this is 7,000 patients, more than 30 days from infection, looking at over 205 symptoms. And on average, patients had 14.5 symptoms in 9 organ systems. And by far and away, the most frequent that we see are fatigue, that post-exertional malaise that I talked about. So you go for a walk down the street and then you need a 2-hour nap afterward, that kind of experience. I wanted to highlight for this also the brain fog, which is almost 60% of the patients. The cognitive, and sorry, I'm at the county hospital and the trauma center, so we'll see some ambulances and helicopters coming in too. Is that okay? But that cognitive dysfunction happening in 55%. Other things that really can affect cognition is sleep, the speech, associated with speech and language issues, feeling lightheaded. Palpitations is one thing, but some patients are really becoming tachycardic into very high levels, which can affect your endurance and cognitive endurance, and headache and other neurologic symptoms. So, you may recognize overlap with a lot of symptoms that patients experience after brain injury too, including fatigue, brain fog, headaches, memory issues, etc. So I think what's really important to note is that if you've had a brain injury before, and this kind of infection could put you at risk for worsening some of these symptoms that you already may have experience with. I think the other study that looked at this was published in JAMA recently, and this is just to kind of support the numbers. What impressed me about this study was that there were persistent symptoms in about 30% of those patients at about 9 months, and it wasn't necessarily different as you might expect in outpatients versus hospitalized. I think I would have, really anticipated that the hospitalized patients had much higher rates of ongoing symptoms, but it was really, in both of these populations that there were persistent symptoms. And this slide really is very similar to the previous one, where the symptoms were pretty similar. So I think another question that we have, so what's causing this? Why are patients experiencing these symptoms and ongoing issues? And as I talked about, critical illness, ARDS, and pulmonary issues really are part of it, but let's talk a little bit about what the direct effects of the virus are. So when you look at the neurologic and neuromuscular issues, if you look at the Wuhan report, about 36% of patients overall and almost half of the patients with severe infections experience some kind of neurologic symptom. So, pretty high rates of stroke, almost 1 in 20 of the severe patients, and not quite as bad in non-severe, but 1 in 100 patients with stroke in those patients. Lots of information coming out about thrombosis and then microvascular thrombosis. Some studies looking at autopsies showing that the microvessels, which feed oxygen and nutrients to the neurons of the brain, were being affected. There may be some direct tissue infection, and clearly we're also talking about kind of systemic autoimmune, immune kinds of issues. So inflammation in the brain, autoimmune disease, which might be targeting receptors on the neurons, et cetera. In terms of what we're seeing in the peripheral nervous system, see a lot of cases of AIDP, so polyneuropathy that is affecting the nerves, and then direct skeletal muscle damage. So lots of patients with muscle markers, one is called creatinine kinase, that is elevated. So, we had a question whether these peripheral neuropathies are something different than the neuropathies we see in the critically ill, and I think they are. I've seen quite a few unusual neuropathies in my outpatient electrodiagnostic clinics. So patients with one arm that's weak because of some strange inflammation, patients with autonomic neuropathies, so their heart rate is really high and it shouldn't be, or they're really dizzy when they stand, those kinds of things. And we think what might be happening is either direct immunologic attack on the nervous system or effects of thrombosis or microvascular. So, and I see the question, AIDP is acute inflammatory demyelinating polyneuropathy. It's essentially just a peripheral neuropathy. And it means that it's attacking the sheath of the nerve. Sorry for, sometimes I get too technical. And effects, I think this is a brain injury talk, but I think it's really important to note that your body as a whole and the health of your body affect your ability to think. And there's been a lot of studies of cardiovascular effects. So patients, the virus binds to what's called an angiotensin converting enzyme receptor. And you don't need to remember that, just know that there's a lot of those on the heart. And when the virus attacks the body, it's using those receptors as a gateway to get into the cells. And there's a lot of evidence that patients are having cardiac dysfunction and cardiac inflammation. So in one study out of China, about 12% of patients had an elevation in cardiac biomarkers such as troponin or developed cardiac arrest during hospitalization. And we saw a lot of patients with heart attacks coming into Harborview. We also saw a lot of patients with cardiomyopathy. So in this one group of 21 severe COVID-19 patients, about a third had cardiomyopathy. And cardiomyopathy is a fancy word, but it just essentially means that the muscle of the heart is not working as well to pump, and that you're not as efficient and you're not as good at perfusing your body with blood. And what that does is it can affect your energy as your system, but it can also have effects on your ability to have cognitive endurance and your ability to think. People feel exhausted and tired and worn out, and can really affect your general health. As I talked about before, some autonomic symptoms. So a lot of patients with what's called postural tachycardia syndrome, essentially they stand up and their heart rate goes very high and that they can't tolerate exercise as well. And that can be due to either being in bed for very long times, like a month. It can be due to neuropathies of our autonomic nervous system and small fiber neuropathies, which affect our ability to regulate our heart and our blood pressures and our how our vasculature is controlling blood pressure. Effects on our neuroendocrine system, and then autoimmune antibodies can do it. So sometimes antibodies to receptors in our autonomic nervous system can affect that. And then looking at this brain fog a little more deeply. So when we look at studies, there's a few studies where they're looking at studies of sustained attention that are showing patients are having difficulties with sustained attention. So they are doing something called the trials A and trials B tests, and patients are struggling to have the expected level of attention that they would pre-COVID. And in multiple studies, lots of patients reporting persistent cognitive issues, as I alluded to earlier. And there's a few things that might be happening here. As I talked about earlier, direct effects on the tissues and inflammation of the brain might be causing some of this. When you get a normal MRI, they don't see things, but looking at PET scans, there does seem to be some effect. This microvascular disease, so the small arteries and that are perfusing the brain may be being affected. And a lot of patients that have low blood oxygen levels or high carbon dioxide levels might be causing that as well. So, and significantly, lots of patients complaining about disturbances in their circadian rhythm, so their ability to sleep. They're, not sleeping well throughout the night, up all night, and obviously sleep has direct effects on your ability to think, to maintain attention, to remember key details, and we've seen that. And another thing that may be impacting mental health is, cognition is mental health. Lots of patients with anxiety or depression, which can clearly have an effect on our cognition. I think this is an important slide. So the cognitive dysfunction is having pretty significant impacts on patients' ability to work. So about 45% in this international study led by patients were needing a reduced work schedule compared to pre-illness. So, this is at least 30 days out. And, that's a huge number of people having to reduce their work hours in order to be able to meet the demands of their work schedule. And fully 22% not working at all due to the changes of COVID. So that has huge impacts on patients' finances, on stress and anxiety, on family and work relationships. That's socially just a huge, huge impact. I've been on multiple NIH calls and some of the national disability groups talking about the financial impacts of this condition on patients. And there's many people having completely depleted savings and complete, just chaos in their financial lives because of getting this illness. And this is just looking a little more deeply at that last slide. I just really want to emphasize again that the 45% that are working reduced hours, it's not because of the changes in the economy and the pandemic, it's directly because of COVID. There are other reasons people have reduced hours or, in this pandemic. Reduced hours over here, but it's due to COVID is really a significant number. And this slide really is looking at what mental health changes we're seeing in this particular virus. I think I saw earlier, a comparison to the 1918 influenza pandemic, and this study looks at other influenza outbreaks, not particularly the 1918 one, but if you look at COVID-19 versus other influenzas, the percentage of new or the probability of a new mental health diagnosis is much higher. So we've seen multiple cases of new psychosis after COVID infection. At Harborview, we've also seen many patients suffering from new mood or anxiety disorders. And these are patients who did not have a mood or anxiety disorder before. This is a new diagnosis. This study also looks at worsening of mental health, and that is also predominant in this. And this is compared to influenza. So, why this is it direct effects of the virus? Is it effects on sleep? Is it effects on, your ability to return to work, your financial stressors? This study doesn't determine that. And we've also all experienced the isolation effects of quarantine and the societal effects of this pandemic. But clearly we have major issues in this population with mental health. So I wanted to switch gears a little bit and talk about vaccination. And I suspect you all are pretty well aware of this by now. So I hopefully I'm not belaboring the point. But there are basically 3 vaccines currently available in the United States. And I think a lot of us use the company names as our main monikers for these vaccines. There's the Pfizer, the Moderna, and the Johnson & Johnson is what they're commonly called. These, you don't have to remember these, but these are the actual names of the vaccines. The important points are, so the Pfizer and Moderna use an mRNA platform. So essentially, this mRNA is in a lipid. It gets into your muscle. Your body uses messenger RNA to, and I'm sorry if it's too tiny to see. I will try to talk about it so you get the information verbally. So both of those vaccines, Pfizer and Moderna, are using a messenger RNA. And what the messenger RMA does is it takes your body's machinery and it builds a protein that mimics the spike protein of the virus. So that is essentially the protein that helps the virus bind to your cells and enter the cells where it does its kind of nasty work and replicates itself. So by building this spike protein in your cells, your body then has an immune reaction to that spike protein. And I'm seeing the chat comments come up. There's some slides that address those in just a second. But your body then develops a knowledge of what that spike protein looks like, so that when COVID does come along, it recognizes it. It knows the spike protein and prevents that virus from attacking your body. So that's how those work. The Johnson & Johnson uses a different technology. So it uses basically an adenovirus vector, and the adenovirus is made weaker essentially, but it does the same work to try to replicate some of the proteins in your body. So let's see. Just a few recommendations. So now the Pfizer biotech vaccine is available. It's approved for 12 and older, essentially. So that was just recently done. My daughter is now scheduled for, I think, next week to get this to get the Pfizer biotech. The Moderna, which is the one that I got, is approved for patients 18 years and older. The Johnson & Johnson is approved for patients 18 and older. You can get vaccinated if you're pregnant, and you can also get vaccinated if you if you previously had a COVID infection. So one thing I'd like to note is a lot of patients who have some of these long-term symptoms are noticing that they're feeling a lot better after getting the vaccine. So we've been encouraging our patients to get that. Why that is, we're not 100% certain. It's possible that there's some reserve of virus in the body or ongoing immune response to the virus in the body, and that when you get the vaccine, it helps the body to eliminate that reserve. But there's a lot of other potential possibilities. So looking at there were some questions earlier about efficacy. So when you look at vaccine efficacy, so efficacy against symptomatic COVID-19, so any symptoms at all, 95%. So if you are directly in touch with somebody with the virus may enter you, but you have a 95% chance that you will have zero symptoms. We're also noticing that that it's likely that patients that are vaccinated are not passing these viruses on to other people. So you are now a roadblock in the transmission chain of the virus. So you'll notice that the CDC guidelines, if you've been vaccinated, you get an exposure, you're no longer required to quarantine because you are unlikely to pass this on. And as far as the rate of severe COVID-19, so these are the patients that are on the ventilators, really sick. There was one in the vaccine group of 18,000 patients, and 9 in the placebo group. The Moderna, there was 0 in the severe COVID group, or in the vaccine group, and 30 in the placebo group. And in Johnson & Johnson, the efficacy is not as good. They're still recommending that you get it if it's the only vaccine available to you, because it does have a great reduction in your rates of moderate to severe COVID, and has 85% efficacy against severe COVID. So I think there was another question about severe side effects. So I think the most concerning side effect has been anaphylaxis, so a severe allergic reaction to infection. So, when you look at the Pfizer, it's about 5 per million. So that's a really, really small chance of having severe anaphylaxis. Most vaccine sites are having people sit and wait for around 30 minutes to just see if they have a reaction, and there are nurses and staff on site to manage that so that you're not getting really sick. In the Moderna, it was about 2.8 per million. Now, if you're looking at other side effects, so there are some side effects that are more common. So a lot of patients with local reactions, especially sore arms, some redness or swelling at the site, and a lot of patients with systemic symptoms. So feeling hot or cold, feeling fatigue, having muscle aches, having headache, and that I have not seen anyone at Harborview with an anaphylactic reaction, but lots of people with these kinds of reactions. And I myself, after the second dose of Moderna, I felt pretty wiped out for about 24 hours, but much better after that, and felt great relief at having to go into these COVID rooms and being protected. And I would also say I've seen a few cases where patients have felt very tired for even up to a couple of weeks, but I've not had a patient where that didn't resolve. So I think it's very possible if you're already having some cognitive changes or have injuries after brain injury, that you may have a recurrence of that, or feel a little worsening in your cognition for a while, just because of the systemic effects of this. But I rest assured that I've not seen anybody that hasn't recovered completely by a couple weeks. The Johnson & Johnson has one additional side effect, and you may have heard also with the AstraZeneca one, which is not currently available in the US, where there's this complication associated with thrombosis or thrombocytopenia, which is really low platelet counts and still pretty rare, and a little more predominant in females. And these are less than, for example, what you would experience if you were taking an oral contraceptive, or some of the oral contraceptives, but still, something to consider. I wanted to talk just briefly, and then we'll have some time for questions, about what we're developing here at the University of Washington to manage some of these issues, and that we're in the transition of converting our clinic to more of a center for post-COVID recovery, rehabilitation, and research. And this will also include patients that are post-ICU, post-polytrauma, or medically complicated patients who've really been through our ICUs and have these multidisciplinary needs. Just to talk a little bit about Washington State, a lot of cases, and almost 22,000 hospitalizations. So if we're talking around, so thrombocytopenia is low platelet counts. It's not blood clots, just answering the chat question, but there are, those vaccines had complications with blood clots and low platelet counts. So so if we're talking about a third of these cases at the upper end having ongoing symptoms, it's still a huge number of patients. So, and if it's less, like 10%, it's still just a very, very large number of patients. So, one of the things in our clinic, we've just seen that there's really a high demand for a multidisciplinary approach after COVID. And we've now trying to partner with internal medicine, family medicine, and some of the subspecialties, including pulmonology, cardiology, neurology, allergy and infectious disease, rheumatology, and psychiatry, because there's not one specialty that completely owns the post-COVID sphere. And this is a disease that can affect many different organ systems. And we really want to address each patient's needs as appropriate. Jana Friedley is really heading the clinic now. I'm participating in some of the research efforts and directing some of the medical aspects of the care and design of those protocols. And then in the new model, we're going to have patients who are not hospitalized first undergo an intake, and they from there would be decided, if you need a medicine visit and what kinds of specialties you might need, as well as what kinds of therapies. We really expect physical therapy, rehabilitation, psychology to be the most important, or I'm sorry, the most commonly used, I shouldn't say important, but then speech therapy playing a role in some of the patients, especially after some of the auxiliary things like sleep and mood and those things are addressed, and as well as return to work issues with neuropsych and rehab psych. And then on the medicine side, we're hoping a lot can be done with internal medicine, and then working with cardiology and pulmonology and neurology especially. And the goal is really to improve, the support in the massive number of cases of the post-acute sequelae of COVID. So I think this is specifically can really affect the brain injury population, because if you already have worked so hard to rebuild a life, and you have ongoing cognitive issues, or you've been able to finally return to work, or you've built a life of social activities and social roles that you really value, and now you get this disease, and if it does have those impacts on worsening your cognition and your function and your mental health and other things, having to go back and rebuild everything is just such a huge effort. And I know, having worked with many of my patients, just how hard they have, worked to get back to something that they really value. And my hope is that the vaccine rolls out soon enough for people to avoid a lot of these things that we're seeing in the post-COVID world. In the future, I think, our real goals here are trying to achieve medical and emotional stability for the patients. We really want to help patients manage symptoms. And, if you've been through the rehab department, that's part of the goal there to help people cope with some of the changes. So, some of these patients were working at high-level jobs as a lawyer or a nurse or, a therapist or something like a computer programmer, or, they're a construction worker, which just required either physical or, really high-level cognitive strength, and now are struggling to return to those jobs. So really trying to help patients cope with those physical and cognitive changes, and then work on supportive of things like sleep and nutrition and exercise and stress management to help support that recovery. And then just really get patients back to moving again, and teach them new things about pacing and injury conservation, which I suspect a lot of people on this call already know well. And the goal is, I think a lot of the post-ICU and post-viral patients have been underserved previously, and we'd like to build out clinical programs and pathways for those patients to really help them recover, and really want to improve patient access to the clinic and also clinic resources. So we're trying to really study this. So there's a lot of research efforts underway, and we're trying to improve some of our materials for patients. I think all of our bandwidth has been a little limited, but we really want to serve that. So I appreciate taking the time. I'd be happy to answer any questions that have arisen, and anything that I can provide.
Yeah, if anybody has questions, feel free to utilize that chat feature, and we can definitely address those. I know off the top of my head, Dr. Bunnell, one question that we've had a lot, and I don't know if you have any information about this, But is there any sort of research or statistics that say that somebody with a brain injury is at an increased risk for vaccine, like severe side effects or anything like that?
Yeah, I have not seen research specific to the brain injury population on outcomes after vaccination for severe side effects. I would say this, that if your cognitive reserve is a little limited, or your cognitive endurance is limited, that you may be more affected for a while. I don't think that, and having seen a bunch of different patients that have gotten the vaccine, I've not seen anyone with permanent sequela of that yet. So I think the risk benefit is really far on the side of the vaccine. And what I have seen is people that have gotten COVID who are really sick and really going on and on. So the vaccine, it's true, I've seen a few people that have felt crummy for a couple of weeks, but then we're okay. Whereas COVID, I've seen people who are still not okay months and months after 9 or 10 months, or worse, on the ventilator, have their lungs bypassed and getting oxygenated through a machine. And I think, having worked in this environment, I'm very concerned that people are underselling the effects of COVID. And I go crazy when I hear people saying it's just the flu, because I've treated a lot of flu and I've not seen it at this level.
Yeah. Not just the flu. My brother died from it week after Thanksgiving. They weren't being careful at Thanksgiving.
I'm so sorry to hear that, and
Me too.
My heart goes out to many people, and I've heard that I've heard that from many different people, loved ones that have passed or gotten very, very sick.
Yeah, no, I have a friend who is my age. I'm 25, and she got COVID severely and was in the ICU, and she never recovered her sense of taste. So that's just something that she's been dealing with for the past 4 months. So the effects are crazy.
Never yet, but maybe she still will.
Yeah, still could in the future.
You never know.
4 months-ish now, so.
Yeah, I've seen some studies on that, and a lot of people are getting it back, kind of 6 to 12 months. So I hope that goes for her. Fingers crossed for your friend. Yeah, it's interesting because I was in my residency as an R2 and the senior in the ICU during H1N1, and that was pretty serious, but it is nothing like what the ICU docs had to experience here. I'm pretty decent friends with Andy Lux, who was spearheading a lot of the efforts here, and boy, it's just a different world.
Yeah. See, I'm not seeing any questions that have come through in the chat. Some people saying their own experiences, they've had to do rehab and have had some pretty substantial side effects from getting COVID. Somebody doing rehab 5 times a week now, trying to recover from a severe COVID illness, and friends who have had brain fog after having COVID.
Absolutely. It's very common, and I hope we're kind of in the stage where we've recognized what's happening, and the next stage is really to find the best treatments and best approaches for this post-COVID sequela. And I'm encouraged at how much effort there is going into it, but it's probably going to be 6 months to a year before we do.
Oh, we got a question and asking from a Carolyn, what can you tell her about the monoclonal antibody treatment? Do you know anything about that?
Oh, for acute severe COVID?
Carolyn, is that what you're referring to?
Is that the one you're talking about?
I'm not seeing a response, but we can go off of the assumption that for that.
Because I've seen some that are, I'm on a couple of studies for where they're looking at using IgG vectors to try to deliver immunomodulators for long COVID. And those are currently under trial. So that's a little bit different area, but there is some acute treatments with antibodies for severe COVID, which do seem to show a survival benefit.
Oh, sorry, I was on mute, but my question was more about on the front end, that I'd read that, if you have the symptoms right there in the first 3 weeks, go after that monoclonal antibody treatment, that's the window of opportunity.
Yeah, and I'm not as much on the front end, so they definitely use it in severe COVID, but I'm not sure about outpatient. I've not seen that yet.
Thank you.
Thank you for that question, Carolyn.
Yeah, but I should also say that I'm not the one doing the initial management. I'm usually the one much further down the road.
Thank you. Yeah, because what I had read in several sources was that was your window of opportunity. Jump on it right then on those early symptoms.
Yeah, in the ICU, they're definitely in the ED, they're definitely doing that for more severe cases.
Well, I'm not seeing any more questions coming through on the chat at the moment. If we want to go ahead and wrap up, we can definitely do that. I definitely want to give people my email address. If they come up with questions later on, I can definitely reach out to Dr. Bunnell and respond to you via email. So my email address is Kelsey, and then the letter R, at BIAWA.org, and I'll go ahead and type it in the chat here so everybody has that. And if you think of a question later, definitely shoot me an email and I will do some investigation and get back to you. Other than that, I just wanted to say thank you to everybody for joining us, and a special thank you for Dr. Bunnell for leading that presentation. So thank you.
I have one more question.
Yeah, go for it, Laura.
I just wasn't quick enough.
No, you're fine.
I'm slow. Is there anywhere I can look up the question that I had earlier, which was, because the information that I had heard is that they have statistics on the 95% is how likely you are to not get an extreme case of it. But the only thing I heard about how likely you are to get it or pass it on once you've had the vaccine was one study that was in a hospital that was 80% less likely to get it or pass it on. But do you know anywhere to look up statistics on that?
Yeah, if it'd be helpful, I can send some of the references
Sure.
that can be sent back out if you want.
Mm-hmm.
Yeah, if you want to send those to me, I can distribute them to everybody who attended.
Yeah,
Goody.
I can send. The CDC has some great sites and some other things, and I can also, to answer that question on the monoclonal antibodies, I can try to look that up for the outpatient setting, which I've not looked at. So my guess is that that's probably still a trial that's happening, but I'll send out what the actual studies are looking at.
Great, thanks for that. And Kelsey, thanks. Are you going to send it out as an email?
Yeah, I'll send it an email to everybody who attended.
Lovely, lovely. Thank you very much.
You're welcome. Thank you, Laura. All right. Well, let's go ahead and adjourn for the day. Thank you so much, Dr. Bunnell, and thank you to everybody who joined us. This was great.
Thank you, guys. Appreciate it.